This video is essentially a continuation of the previous one, which we saw on the B cell basics. So what we are going to see in this video is the B cell receptor signaling, immunoglobulin properties and function, probably a little bit on the memory B cell and memory T cell formation, and a little maybe on the congenital immunodeficiency syndromes. So let us start with the B cell receptor functioning first. So you have a B cell receptor functioning here, signaling pathways, how it works. So first you have the antigen binding over here. This antigen binding is going to activate this B cell receptor. Activation results in activation of one important kinase called PI3 kinase. So this kinase is going to, so you know it's a kinase, so its function is to phosphorylate. So it phosphorylates phosphatidylinositol diphosphate to phosphatidylinositol triphosphate. And this phosphatidylinositol triphosphate, PAP3, has multiple other downstream signaling is there. For example, it's going to activate your AKT pathway, and it's also going to activate your BTK pathway. BTK is nothing but Bruton's tyrosine kinase. This is most of the time exclusively seen in B cells only. That's why it's very, very important pathway for B cells. This Bruton's tyrosine kinase for B cell survival, proliferation, and activation. So now once AKT pathway and BTK pathway is activated, you know that you're going to accelerate the cell division and survival. But how they do is something also very important. AKT pathway is generally going to activate the cell cycle, and it's through the mTOR pathway. mTOR signaling, you know very well, it activates the cell cycle and cell proliferation through production of lot of anti-apoptotic proteins like BCL6. At the same time, BTK pathway, this Bruton's tyrosine kinase, is going to convert this something called PAP2 to something called IP3 and DAG, inositol triphosphate and diacylglycerol, through activation of a enzyme called phospholipase C. So this Bruton's tyrosine kinase is going to activate this phospholipase C, which is going to mediate the conversion of PAP2 to this inositol triphosphate, IP3 and diacylglycerol. This IP3 inositol triphosphate, through calcium influx and calcium dependent activation of another pathway called NF-kappa B pathway. So DAG, now it's going to activate another pathway called RAS-MAP kinase pathway, through which your BRAF genes and all these things are involved. So RAS-MAP kinase pathway will be activated, both of which are going to accelerate the cell proliferation and survival. So anyway, even though the activation pathways are important, but it's also key to understand the two kinases. One is the PI3 kinase and the second one is the BT kinase, that is the Bruton's tyrosine kinase. Both are very, very important for B cell survival and proliferation downstream. So that is the reason why this two kinases has become a very important therapeutic targets also. For example, this PI3 kinase can be blocked by a drug called idelalisib, and you have other similar drugs like something called copanlisib, then you have something called alpelisib, then you also have something called a duvelisib. Most of them are used for relapsed lymphomas, typically non-Hodgkin lymphomas like CLL or relapsed follicular lymphomas. But in general, you can remember these are important for lymphoma treatment. This idelalisib and copanlisib also. Most important will be the idelalisib for exams. And similarly, this Bruton's tyrosine kinase can be blocked. This kinase can be blocked by a drug called ibrutinib, which has multiple applications recently. For example, it can also be, this ibrutinib can also be used for relapsed CLL. It is currently used for relapsed mantle cell lymphoma. Then it can also be used for chronic graft versus host disease. A lot of applications are there for ibrutinib right now. But anyways, like ibrutinib, you have other drugs like, for example, acalabrutinib. Then you have something called zanubrutinib. So many drugs are there in this group apart from ibrutinib, but the most important will always be the ibrutinib, where it can be used for relapsed CLL, I told you, relapsed mantle cell lymphoma, and also for chronic graft versus host disease. Please don't forget these two drugs, that especially the idelalisib, which is a PI3K inhibitor, and the ibrutinib, which is a BTK inhibitor. So these are the important drugs that acting on the BCR receptor signaling downstream, because BTK deficiency leads to one important disease which we are going to see in the congenital B cell immunodeficiency syndrome, which we'll see in the immunodeficiency area. Because Bruton's A gamma globulinemia is there. That's what I'm trying to talk about. So we'll discuss later on. Now the next segment we are going to move into the immunoglobulin properties. So let us discuss on the immunoglobulins. So you have immunoglobulin. Let us see the immunoglobulin function. So you know there are two cleavage studies, papain and pepsin, which we'll see in some time. But the two immunoglobulins, the chains of the immunoglobulins. Let us see first. This is the heavy chain, which I'm going to shade in the red color. This is a heavy chain, and this one that I'm going to shade in the blue color. These are the light chains. You can see this. These are the light chains. So an immunoglobulin essentially is made of a two heavy chain and a two light chain. You can see that. Remember, if you see the binding sites, like heavy chain and light chain are all right, but if you see the binding sites, they are completely different. So first see what are the heavy chains. See, remember, this red one is the heavy chain, and this blue one is the light chain. Remember, an immunoglobulin may contain any heavy chain. For example, the heavy chain, this portion, this Fc portion is the one that determines the heavy chain. The heavy chain can be of anything. It could be gamma, alpha, anything. But remember, the light chain can be only two. It could be either a kappa or a lambda, which means why I didn't put kappa here, lambda. That is, an immunoglobulin can never contain a kappa here and a lambda in the other arm. It can either contain a kappa or a lambda, but never both. That's a very important point to understand. But they will either contain a kappa or a lambda. At the same time, if you break the immunoglobulins functionally, so first you can break here at this point, where you can tell that this particular zone, this area, these two areas, these are what we refer to as something called Fab regions. These Fab regions are the ones which are going to bind the antigens. These Fab regions are the areas which are going to bind with the antigens. These are the antigen binding areas. This is what we call Fab. You have two fragments actually, two sides, which is one is made of heavy chain light chain, another side is made of heavy chain light chain. So this is the entire area is what we call Fab. This is the fragment of antigen binding. So that is why it's called Fab, fragment of antigen binding. So what are the properties of Fab, if you ask me? So properties of Fab will be, it is made of both heavy chains as well as light chains. You can very clearly see it is made of heavy chain as well as the light chain. At the same time, this is the one that is going to contain the hypervariable and the variable regions. This is the one that is going to contain the hypervariable and the variable regions. Similarly, this Fab region is the one that is extremely specific and determines the idiotype, not the isotype, idiotype of the antibody, which is absolutely specific for a single antigen, which means they will bind only to a single antigen. Absolutely specific for only one particular antigen. That's why it determines the idiotype of the particular antibody. Now let us come to the second area. This is what we refer. This is the second functional area of the antibody. This is called Fc portion of the antibody. So what do you mean by Fc portion of the antibody? It's a constant portion. And what are the properties of this constant portion of the antibody? Which means it is constant. This constant portion means it's going to be constant for a particular antibody. It's not going to change at all. But Fab region is not like that. It's going to be variable. Fab region is completely different. They are variable as well as hypervariable regions are there, and it's going to be different for different antibodies. But this Fc portion is always constant, and it is the one that determines the isotype of the antibody. Isotype means whether it is IgM or whether it is IgG or whether it is IgA or whether it is IgD or whether it is IgE. This particular isotype of the antibody is determined by this Fc portion only. So then what is the constant region made of? Constant region is made of only heavy chains. That is very important. You can see very clearly they are only made of heavy chains. They are not made of light chains at all in the first place. They are only made of heavy chains completely. So which means the heavy chains are the one I can indirectly tell that is going to tell you the isotype of the particular antibody. This is also one question that is asked in 2016, I guess, in microbiology section, where the heavy chain is the one that determines. Everyone expects the constant, region, but they are given an option called heavy chain is the one that determines the isotype of a particular antibody. That is true, absolutely true. Light chain does not determine the isotype of the antibody. It's the heavy chain that determines the isotype of the antibody, because constant region is made only of the heavy chain. Apart from that, What is the function? Because we are dividing into functional points. So what do they bind? They bind to the immunological cells. Binding of immunological cells. Remember, binding of the antigen is through Fab region, but binding to the immunological cells is through your FC portion only. And this FC portion is also the one that going to activate the complements. Complement activation is going to be mediated by FC portion only. That is why this is very important, because remember, FC receptors are there, which is there for complement as well as for phagocytic. Especially what are the immunological cells? There are two immunological cells which harbor these FC receptors, which can detect the antibody and they can react appropriately. So one is the phagocytic cells. So which means a phagocytic cell, once they recognize the FC portion bound to some antigen, they phagocytose them and they kill them. Very simple. At the same time, second one is the cytotoxic cells. Like you have cytotoxic T lymphocytes and especially natural killer cells. All these things also possess these FC receptors. The moment they recognize these FC receptors, that is the antibody bound to some antigen, they are going to degranulate and they are going to kill that particular cell. At the same time, they can be seen on the mast cells also for the purpose of degranulation, which recognizes the IgE typically, FC portion of the IgE typically. Like this, you have so much of immunological cells can recognize this FC portion. That is the actually functional importance of this FC portion. So you can see these are the importance of FC portion and the Fab region. These are the two functional components. Structurally, you can divide into heavy chains and the light chains, and functionally you can divide into the Fab portion and the FC portion. Remember, Fab portion has both heavy chains and light chains, and FC portion is going to have only the light chains in particular. Sorry, heavy chains in particular. So what are the cleavages going to heal? I told you the two cleavages. One is the papain cleavage and second one is the pepsin cleavage. So what papain cleavage is going to heal? I told you papain is going to break at this point. So papain is like this. Papain is going to break at this point. So once papain breaks at this point, what you're going to see is you're going to see two Fab fragments. Both are split into two, and separately one FC fragment you're going to see, which means two Fab fragments and one FC fragment. This is what papain is going to do. And what pepsin is going to do is pepsin is going to break the bone at this area. It break the backbone at the FC region. So what you will be really seeing is, like our intact Fab region, which means there will be two subunits in the Fab, both made of one heavy chain and one light chain, which means it will be both together. We are going to call it as Fab, like apostrophe 2. So this is a single Fab region, but like it's with a single antigen specificity, but it will be united together. The heavy chain and the light chain part, both sides, both arms will be united together. So this is Fab, one Fab, and you will get multiple FC fragments. The FC will be cleaved into multiple FC fragments, but you will have a single Fab region as a whole big molecular weight component. So why this pepsin and papain cleavage is very important? Because these are early preliminary studies. These are the ones that gave rise to the understanding of what the immunoglobulin structure is really. So that is why these studies are really important for exams. But remember, papain cleavage 2 Fab and 1 FC, and pepsin cleavage 1 Fab and multiple FC. Simple. That's how you remember. And what are the functions of the antibodies? In a nutshell. So this diagram will tell you the functions of the antibodies. The first important function of the antibodies is neutralization of the antigens. Again, the most important neutralizer is immunoglobulin G. And similarly, you have second function of the antibody, that is opsonization of the antigen. Opsonization means they cover the antigen with antibodies so that they can facilitate phagocytosis, or they can activate the cytotoxic cells like natural killer cells to degranulate and kill the cell. So for killing the cell, again, opsonization is very important. So again, the best opsonizer, if somebody asks you, again I will tell it is IgG, one of the best opsonizers. Then third function, so that is activation of the complement system, complement activation. Complement activation again happens through this FC portion only. The most important complement activator is the IgM. IgM is supposed to be the best complement activator, followed by IgG, followed by a little complement activation is also seen in IgA, whereas IgD and IgE generally do not activate the complement. That's very important point. Even though some microbiology textbooks will give Ig, A do not activate the complement, but I generally believe IgA also is going to activate the complement, to be honest. So this is one of the important complement activators. So these are the various immunoglobulin functions. So now let us see the immunoglobulin properties. What are the properties of the immunoglobulins? One is the specificity and second one is going to be the diversity. For determining specificity, you need antigen. That's why it's called antigen specificity. Remember, for diversity, it is antigen independent, which means it's determined by the genes, not by the antigens. So antigen independent, so diversity. So second thing, what is the reason for specificity of the antigen? Specificity actually can be increased or decreased to a particular antibody through a process called somatic hypermutation and affinity maturation. This process we have discussed already in the previous section. So specificity of a particular antibody can be either increased or it could be a disadvantaged mutation, which we have discussed already. So but the idea of the body is to increase the specificity of the antigen through somatic hypermutation and something called affinity maturation, whereas diversity is achieved through recombination, like this VDJ recombination. So this is the one that is going to cause the diversity of a particular antibody, or you can call it as simply VJ recombination. Why I told VJ recombination? Because this VDJ recombination happens for the heavy chains and this VJ recombination is going to happen for the light chains. That's why I told you two separately, VJ recombination, VDJ recombination. This is the one that determines the diversity. So specificity, also determines the class switching as well. Class switching is also an important event that happens through this specificity, through somatic hypermutation and affinity maturation process, whereas diversity is something random. It happens randomly. It is not, it is involved through a process called TDT, this terminal deoxyribosyl transferase, and you have, this is the one that is going to mediate the diversity of the antibody. But the somatic hypermutation, this is through this specificity is through something called activation induced cytidine deaminase. These are some of the differences between what you mean by specificity and what you mean by a diversity. In general, remember, specificity is antigen dependent and diversity is antigen independent, and what are the processes that are involved and what are the enzymes that are involved in each and everything you have to understand. Then let us see some of the important properties of the immunoglobulin types. What are the immunoglobulin types and what are the properties of this immunoglobulin? The first one, you have IgM, and the second one you have IgG, and the third one you have IgA, and the fourth one you have IgE, and the fifth one you have IgD. Remember, first of all, this IgM is supposed to be the IgG is supposed to be the most common antibody in the blood, which means antibody in highest concentration in the blood. If they ask, is the most important property, antibody that is present in highest concentration in the blood is IgG only. Then if they ask you second most common antibody in blood, which means antibody that is present in maximum concentration but second most, if they ask you, answer is IgA. But IgA has one important excellent property. This is the antibody that is most common in the body, which means this is the antibody that is present in maximum concentration, that is maximally secreted by the body. Maximally secreted by the body. How you can ask me, sir, how is it, what you're confusing? So blood IgG is maximum, but overall in the body it's IgA. Yes, true, because IgA is a mucosal antibody. See the mucosal surface, where it starts from. It starts from the mouth to anus. You have a lot of GAT mucosal surface. At the same time, you have respiratory tract. The entire whole lot of respiratory tract is again a mucosal surface. What is the surface area of the mucosal surface of GAT and your lungs combined, your respiratory tract combined? It's too much. So much of surface area is there. Entire surface area is filled with IgE. So highest amount of antibody secreted in the body per day or per year, whatever in the entire lifetime, is IgA only. But the maximum amount of antibody that is present in the blood, if you ask me, it is IgG. Concentration is high in the blood is IgG. The body, it is IgA only, definitely. Maximum amount of antibody. Then let us go for some of the important properties. First one is what is the heavy chain composition? It is mu, it is gamma, it is alpha, it is epsilon, and it is delta. So this is the heavy chain composition. And what is the structure? Structure, typically this IgM comes in the form of pentameric structure. So it will be having pentamer, which means five IgM molecules will combine together and form a pentamer usually. IgG is typically a monomer, and IgA can be like a monomer, or it can be a dimer also. Either it can be a monomer or IgA can be a dimer also. Remember, circulating IgA, which means IgA that is present in the blood, I told you, that will be usually a monomeric antibody. whereas there is an entity called a secretory IgA, those that are secreted through the mucosal surfaces. This is called secretory IgA, that will be usually having a like dimeric structure. Remember, who's holding the immunoglobulins together? For example, if somebody asks you who's holding this immunoglobulins together, suppose a pentameric or a dimeric antibody, that is the J chain. That is called the J chain. J chain is the one that holds the immunoglobulins together in a pentameric or a dimeric structure. Similarly, in a dimeric structure, who's going to hold the two IgA together is going to be the J chain. But additionally, this dimeric IgA has one other important thing, that is called, they also have another chain called a secretory chain. This is called a secretory component. Remember, the secretory component is not actually coming from the plasma cells. These are added by the gastrointestinal mucosal cells. That is to increase the stability of the IgA, especially when they are going through the acidic. For example, in the stomach you have acid, in the duodenum and the jejunum and all, you have these pancreatic juices which might cleave the antibodies, and your antibodies might become, these also proteins, and so they might cleave and the antibodies might become non-functional. So to avoid that, the protection from this gastric juices and the stomach acids and all these things will be by the secretory component that is also present, that is secreted by the mucosal cells themselves. Secretory component, this is due to post-translational modifications of a protein. So this is a secretory component that is present in the IgA exclusively, in the secretory IgA, especially in the dimeric component. Then typically, like your Ig will be a monomer, and IgD, that delta also will be a monomeric structure only. So all these things, this is also monomer, and this is also going to be a monomer. And if they ask you in the serum, I told you 80% is contributed by IgG only. In the serum, the total amount of immunoglobulins, if you ask, 80% is by the IgG only, 15% is only by the IgA, 5% is by the IgM, 0.002% is by IgE, and only 1% is by IgD. So you can see maximum is the IgG only in the blood. There is no doubt about that. If they ask you half-life of each and every antibody, so 5 to 6 days for IgM, 21 days for IgG, again 5 to 6 days for IgA, 3 days for IgE and IgD, which means the maximum half-life, if they ask you, it is for IgG only. Ig itself has many subtypes are there, which I'm not going to talk right now. So 21 days, maximum half-life is for IgG only. It's for 21 days almost. And what about the molecular weight? Molecular weight, if they ask you, it is approximately 900,000 for IgM, 150,000 for IgG, and 385,000 for IgA, and 200,000 for IgE, and 180,000 for IgD. So now you can see very clearly the molecular weight is maximum for IgM only, because naturally it's a pentameric structure, you can understand. IgM will have the maximum molecular weight. Similarly, the least molecular weight, if you see, it is for IgG. These are some of the trivial questions you might get in exam. The least molecular weight is for IgG only. Next, whether it crosses placenta or not. Crosses placenta, none of the antibodies can cross the placenta except IgG. Ig is the only thing that can cross the placenta. Very important point again. This is very important, especially when you're understanding your RH incompatibility and all. Then what about the Fc binding? Fc binding is not seen in majority of the antibodies, but except two antibodies, that is IgG and IgE. IgG generally binds to the phagocytes and cytotoxic cells, whereas IgE binds to typically to the mast cells and the basophils. For the degranulation, IgE is very important. So these are the two antibodies that have Fc binding, which means these are the areas where you have Fc receptors and Fc binding interactions will be there. And next thing, if you ask about the complement fixation, I told you IgM has the maximum complement fixation. IgG do have a little bit good complement fixation. IgA very little, and IgD and IgE do not have any complement fixation at all. So maximum complement fixating antibody is IgM only. There is no doubt about that. And if they ask you the function of each and every antibodies, IgM is the most important antibody for primary response. That's why after an infection, for early diagnosis, this is very, very important. For early diagnosis of a particular infection, this IgM antibody presence to a particular organism is really, really important. For example, you do a dengue IgM, you do a scrub typhus IgM, don't do a scrub typhus IgG or a dengue IgG to detect ongoing dengue infection, because this is one of the earliest signs of a infection from a particular organism. That is the reason why this is for early diagnosis, because it's an antibody of primary response. At the same time, it is the best complement fixing antibody, but do remember this antibody cannot cross intravascular surfaces, cannot cross vascular compartment. Cannot cross vascular compartment. At the same time, fourth property of this Ig is they can form surface immunoglobulin as a B cell receptor. Remember, in B cell receptor it will be monomeric form only. If it's a B cell receptor, I told you already, if you take this is a B cell, there will be B cell receptor, and this could be surface IgM. I mean, this IgM could form the B cell receptor. Suppose if IgM forms the B cell receptor, it will be monomeric only. But circulating form of IgM will be pentameric usually. But B cell receptor related IgM will be monomeric only. Remember, it cannot cross the vascular compartment, which means it will stay within the vascular compartment only. It cannot move outside the vessels because of the huge structure. You can remember highest molecular weight and the pentameric structure. Remember, this is the antibody of the secondary response, which means for long-term immunity. Remember, it is an evidence of past infection. Usually whenever IgG is there, it is an evidence of past infection or a chronic infection. Evidence of a past infection or a chronic infection from a particular infection. For example, if you have a dengue IgG, which means it might be evidence of a past infection. HIV, if you see this Ig antibodies against this GP120, GP14 and all, means it indicates it is a chronic infection. So either it can indicate a past infection or a chronic infection, and it's the main antibody of second response, which means this is the one that's going to produce a long-term immunity. Long-term immunity, as I already told you, it is the best opsonizer and it is the best neutralizer also, neutralizing antibody also. But it is not the best complement activator, but even though it can activate complement, it's not the best complement activator. It's the best opsonizing and neutralizing antibody you ever get. Similarly, you have IgA also. IgA typically, I told you, is the antibody that produces the mucosal immunity. Antibody that gives rise to a mucosal immunity is IgA only. As I told you, the secretory component is the one that protects the IgA, the dimeric IgA, from getting dissoluted by various proteases and acids in the mucosal surfaces. But typically, this is the very important for mucosal immunity. And if they ask you most abundant antibody in the body, you have to answer IgA only. There is no doubt about that. Most abundant in the blood is IgG. Most abundant antibody in the body is IgA only, without a doubt. And IgE is very important for mast cell and basophil degranulation, especially for allergic responses. This is an antibody of allergy. This is very important for allergic responses, especially for type 1 hypersensitivity reaction. Very important. So this antibody. Apart from that, we don't have that much sense. We don't know the function. We don't know what is the function of IgD. IgD's function is literally unknown. We don't know, it's enigmatic. But many times you can see the surface IgD as a B cell receptor. So probably as a B cell receptor, it has got a very important function. But we really don't know. But at the same time, this IgD as a B cell receptor is very, very high in follicular B cells, especially that B2 group, which is follicular in nature. The marginal and B2 marginal cells in the spleen and B1 group of B cells are more of surface IgM more than IgD. But surface IgD is very high in number, probably in a your B1 follicular group of cells, which means these are the main B cells. Follicular B cells are the main B cells of the adaptive immunity. So probably this IgD plays a very important role in signaling the adaptive immunity. So that is the idea. But apart from that, we don't know what is the real function of the IgD that is circulating in the blood. But anyways, so these are the various functions of the different antibodies that you have to know. After knowing these various functions, let us see some of the subtypes of the IgG itself, because IgG itself has 4 subtypes. You have something called IgG1, you have IgG2, then you have IgG3, then you have something called IgG4 also. Remember, IgG3 is the one that has the lesser T half, even though I told you overall your T half of the IgG is 21 days, but this IgG3 subtype is going to have a little bit of lesser half-life of 7 days. Even though I told IgG is like is a late response or an antibody of secondary response, but if they ask you the first IgG antibody to appear very early, which IgG group appears? IgG3 only. Clear? And IgG3 is one of the early protection, means it somewhat resembles IgM. Like for example, among the IgG, this IgG3 is the best complement activator. Complement activator. Clear? IgG3 is one of the very poor, one of the best complement activators among all the IgG classes, IgG1, IgG2, IgG3, IgG4. Similarly, if you ask about the IgG2, IgG2 is the one that among all IgG itself, they cross the placenta very freely, but IgG2 is the one that poorly crosses the placenta. Poorly crosses the placenta. Similarly, this IgG1 is the one that has the best phagocytic binding ability. Best phagocytic binding ability. Very important points. Very simple. I told you IgG1 best phagocyte binding ability. IgG2 among all the Ig antibody, that's the one that poorly crosses the placenta. And IgG3 is the one that is, even though I told you IgG overall has a half-life of 21 days, but IgG3 is the one that has the least half-life among the Ig subclass, like 7 days. It is the one that appears the most early in an immune response, even though it's a second response. Still, in the second response, the most earliest antibody to appear in the blood among the IgG class is IgG3, and it's the one that is the best complement activator among all the IgG3 and Ig classes. It is the one that is also going to have the lowest half-life, that is 7 days. I told you already. So these are some of the important properties, interesting properties of the IgG subclasses that you might be asked in exams. Then with this, we will be moving on to another component called the immunological memory. Another component called immunological memory. Memory is something essential part of the adaptive immunity, because you need to remember the antigens so that the next time they come, you have to kill them very faster. So the memory can come in the form of memory B cells. And second one, you can also have something called memory T cells as well. Memory T cells also. Both can be there. Memory B cells, I told you already how they form is by, I told you, we are not going to discuss in detail. I told you initially you will have centroblasts. These centroblasts are going to form centrocytes. These centrocytes initially by the CD40-40 ligand interaction by the T cell. So they receive a survival signal from the T cell. That's CD40-40 ligand. All these things we discussed in the previous video. CD40-40 ligand interaction, T cell signal will be there. And based on the survival stimulation by the T cell signal, they can divide in, they can go into either antibody secreting plasma cells, or they can go into memory cells, memory B cells. So this is our hero now. So who's going to cause the memory B cell formation? So if you ask me who's going to cause the memory B cell formation, two things. One, the sustained binding. So two things is going to cause the memory B cell formation. One is the sustained binding of CD40-40 ligand interaction. Sustained CD40-40 binding will stimulate the sustained stimulation of the B cell by this manner can convert the B cell into a memory B cell through activation of lot of downstream pathways. At the same time, interleukin 10 synthesized by the T cell may also stimulate the B cells to go towards memory B cell pathway, especially if the centrocytes are stimulated by interleukin 10 from the T cells. So these are some of the important things that you have to understand about the formation of memory B cells. And these memory B cells, I told you the important marker is CD45RO. Please remember, this is not only a memory B cell marker, this is a memory cell marker, that's all. It can be seen in a memory T cell also. It's not like this is a marker. Apart from that, we have discussed in detail about what are the markers that will be seen on the memory B cell. So these are the memory B cells. And remember, memory B cells will contain surface IgG. They can contain surface IgM or surface IgG or even surface IgA also. Anything they can contain. Very commonly they will contain this surface IgG only. Which means the next time, what is the advantage of memory T cell is, next time if the same antigen comes, you know very well The moment the centrocytes are formed means centroblast centrocyte formation has happened means this centrocytes means these are selected cells. These are selected cells which have high affinity for the particular antigen. So which means the receptor that they possess is also going to have very, very high affinity, number one. The next time if the same antigen comes and if the same antigen is exposed, the idea is there is no need for centroblast centrocyte activation and all. Straight away they become plasma cells and they start secreting antibodies, which means the response is going to be extremely quicker. I told you, if the first time the antigen is coming means you need all this process like T-dependent activation, like both has to shake hand at the cortex paracortex area, then they have to create a germinal center reaction where centroblasts have to go for somatic hypermutation, then centroblast has to be selected, then that will become centrocytes. Centrocytes has to then again receive survival signal from the T cells. From that they will become plasma cells and they secrete antibodies. So all this process is not needed. If a memory B cell is activated, straight away immediately they will go for plasma cell formation and they will start synthesizing the antibody, that is the high affinity antibody, straight away itself without any delay. That is the reason why this is also one of the memory B cell formation is also one of the important reasons why you give a booster vaccines and all, because the response is going to be much faster when you apply a booster vaccine. At the same time, that's the reason also they tell the primary response is much slower compared to the second. The second exposure is the response is much faster compared to the primary exposure. So that all these things is due to the memory B cell formation only, which is really important. So all these things to understand. And next thing is you have memory T cells are there. So whenever you have memory T cells can be two types of memory T cells are there. One is called effector memory T cells, and second one you have something called central memory T cells. Effector memory T cells, and second one you have something called central memory T cells. These effector memory T cells will be typically seen in the circulation and they will be typically seen in the peripheral tissues. They migrate to the peripheral tissues. And the central memory T cells typically locate within the lymphoid organs. That is secondary lymphoid organs like lymph nodes, spleen, everywhere. They will be pooled in the lymphoid organs. So these effector memory T cells, typically they will be CCR7 negative. Then only they can move out. I told you the CCR signaling is very important for homing within the lymph node or a secondary lymphoid organ or a primary lymphoid organ. So the CCR7 negativity is very important. That's why they move out of the secondary lymphoid organs. But the central memory T cells will be CCR7 positive. All the things, the basics we have seen already. So effector memory T cells will be CCR7 negative, whereas central memory T cells is going to be CCR7 positive. The effector memory T cells can be either CD4 positive or CD8 positive T cells. Remember the idea of producing a CD4 and CD8 positive is because to form a quick response. If the CD4 positive T cell is encountering a same antigen again, they will immediately secrete all the cytokines and they immediately start activating all the B cells and everything will be very quick. Similarly, CD8 positive effector T cell memory cells is going to produce quickly all the cytotoxic enzymes and is going to quickly kill the particular target cell and the target antigen. So all these things are really important to understand. So these are the types of memory cells you have in your body. One is the memory B cells and second is the memory T cells you have. Memory T cells can be divided into effector memory T cells and central memory T cells. Effector memory T cells are typically CCR7 negative and the central memory T cells are typically CCR7 positive. That's what you have to understand. So next thing we are going to deal is on the immunodeficiencies, congenital immunodeficiencies. Congenital immunodeficiencies. Congenital immunodeficiencies can be divided into three types. One is called B cell immunodeficiencies. Then T cell immunodeficiencies are there. Then you have combined B and T cell immunodeficiencies. So the most important B cell immunodeficiencies will be, in exam very important, it's a Bruton's A gamma globulinemia. Second one you have something called a selective IgA deficiency. Selective IgA deficiency. Third one you have something called common variable immunodeficiency, CVID, common variable immunodeficiency. And T cell immunodeficiency, you have something called a DGeorge syndrome, then something called hyper IgE syndrome, otherwise referred to as something called a Job syndrome. I already told you STAT3 deficiency, we discussed already in the T cell basics. Then you have something called IL-12 receptor deficiency, interleukin 12, receptor defect, which we'll discuss in some time. Then two other things here, something called Apposite syndrome. This Apposite is also referred to as something called type 1 autoimmune polyendocrine syndrome, which we'll discuss there in endocrinology. And here something called IPEX, immune polyneuropathy, X-linked again, which we're going to discuss in the endocrine chapter only. And combined B and T cell, here comes something called SID, that's called severe combined immunodeficiency. In SID, one important thing is this is very famous in 1970s because of one fellow called David Vedder, one patient, the child is called David Vedder, who expired in I think 1984. His name itself came, it's a bubble boy syndrome, where that boy, because of severe immunodeficiency, they are placed within the bubble, like in a protected sheath of plastic throughout the life. So he cannot come out and expose to any antigen because of severe immunodeficiency. That's called bubble boy syndrome. I'll show you the picture later on. Second one, here something called Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome. Third one, you have something called hyper IgM syndrome. This is due to defect of one important signal, which I told you, the most important signal for B cell activation is CD40 ligand, for somatic hypermutation, for class switching, for memory cell formation, for plasma cell formation, for everything the CD40 ligand is important. So that is defective in hyper IgM. That is the problem. Because the class switching will not happen, so only IgM will be produced throughout their entire life. That's why it's called hyper IgM disease. Then you have something called ataxia telangiectasia. Ataxia telangiectasia. So this is the general, differentiation into a, how the immunodeficiencies are classified into a B cell, into a T cell, and a B cell and T cell combined immunodeficiency. So let us see first what are the features of Bruton's A-gamma globulinemia. So in Bruton's A-gamma globulinemia, this is called X-linked Bruton A-gamma globulinemia because it's an X-linked recessive disorder, which means males are the ones who are going to be affected, number one. So the defective gene is going to be the BTK. We already told you Bruton's tyrosine kinase gene. The Bruton's tyrosine kinase protein is going to be less. So that is the defective gene here. This BTK is very, very important for B cell survival and proliferation, especially for the mature B cells, because B cell receptor signaling is very important for movement of the pro B cell to pre B cell and pre B cell to the immature B cell, immature B cell to the mature B cell. So if BTK is not there in the bone marrow itself, the antigen exposure cannot be recognized, and they will be reduced because the cells will go for apoptosis, and there will be reduced production of mature B cells. The immature and mature B cells will not be produced, and there will be reduced production of mature B cells. That is the idea. Remember, antibodies are not needed for the first 4 to 6 months because the breast milk secreted by the mother. So this disease will not have B cells and they won't produce antibodies, which means first 4 to 6 months the child will somehow manage because the antibodies from the mother's milk. But after 4 to 6 months is where the disease will manifest. This is where it's going to manifest. So manifestation will start around 4 to 6 months of age, after 4 to 6 months of age only. And what are the important thing that is going to get is, the patient is going to get a lot of pyogenic infections. Especially these antibodies are very important for protection against encapsulated organisms like pneumococcus, Haemophilus influenza, and Neisseria species, especially meningococcus. So all these things will be attacking the child, and there is a lot of chance that the child may die of one of the fulminant sepsis due to one of these organisms, especially encapsulated organisms and pyogenic infections. And patients will have hypoplasia of lymphoid tissue. Hypoplasia of lymphoid tissue. Remember, if you ask me the diagnosis, how will you make a diagnosis? The child who is presenting with, because lymphadenopathy is not seen. Remember, the moment they give lymphadenopathy, that rules out this X-linked Bruton's A-gamma globulinemia. It's not possible. How can you get a lymphadenopathy? Lymphadenopathy is due to generation of a germinal center reaction. By only if the B cells are coming to the lymph node, you will get this germinal center reaction, lymphadenopathy also. Lymphadenopathy is impossible in X-linked Bruton's A-gamma globulinemia. So don't diagnose if the patient has lymphadenopathy, not possible at all. So diagnosis will be absent or low B cells, very reduced number or absent B cells will be there in the blood. But the patient will have a normal T cell count, and the patient also will have reduced immunoglobulin classes, immunoglobulins, all immunoglobulins, not only like IgM or Ig, not selective. Every single immunoglobulin should be will be deficient in this patient. So reduced immunoglobulin levels of all classes will be there. So this is how you diagnose a X-linked Bruton's AIJ. Ultimately, genetic analysis is very important, but these are the things that will give rise to a clue that the patient is likely to have X-linked Bruton's A gamma globulinemia. Then you have something called a selective IgA deficiency. If they ask you the most common congenital and most common primary immunodeficiency, answer must be selective IgA. It's the most common among all. So among all the congenital immunodeficiency if you see, primary immunodeficiency if you see, this selective IgA deficiency tends to be the most common, and the genetic defect underlying the selective IgA deficiency is still now not known. We don't know. Unknown IgA deficiency. Remember, IgA is a mucosal antibody. So typically the patient will be suffering from defective mucosal immunity. That's the idea. So the patient will be having defective mucosal immunity. Many times the patient can be asymptomatic. Suppose if they are symptomatic, they will be suffering from mucosal infections predominantly. Asymptomatic is most common usually. Many times they will have IgA deficiency but will be subtle and patient will not have any problem. But if they are symptomatic, typically they will be suffering from mucosal infections. Typically they will be suffering from chronic diarrhea, recurrent pneumonia, candidiasis. This is the thing they will get. Typical lot of mucosal infections are what they are going to get. So this is what is going to happen. But this candidiasis is generally rare because candidiasis is a feature of, they might get, I've seen patients, but typically candidiasis means it goes towards cell-mediated immunity problem rather than a humoral immunity problem. You can get this chronic diarrhea and pneumonia, especially this diarrhea is what is the most important for exam. Diarrhea is what they will ask you because diarrhea is typically due to reduced IgA, chronic, like diarrhea. And there is increased risk of developing gluten hypersensitivity. These patients also have very high risk of developing gluten hypersensitivity, which means they are at very high risk of developing celiac disease, and also they are at very high risk of developing IBD, and also they are at very high risk of developing atopic disease also. If you take celiac disease and see, they would have given 5% of the celiac disease will have selective IgA deficiency. Almost 1 in 20 patients of celiac disease will have selective IgA deficiency. It's a very common thing in celiac disease patients. If you take a pool of celiac disease patients, that's why they are prone for increased risk of gluten hypersensitivity, IBD, and atopy. All these things are very important. In this, the most important clinical picture will be the chronic diarrhea. That will be the most important. Most of the time in exam, you can diagnose selective IgA deficiency when a child or an adolescent or a young adult, especially in this age group, they are suffering from a chronic diarrhea where you don't have any, like family history, clear family history is not there. At the same time, patient is suffering from other problems like recurrent pneumonia in the childhood. In those conditions, you can diagnose IgA deficiency. If they ask you the next investigation to do serum IgA levels. That's what you are going to do. So, diagnosis is based on reduced serum IgA levels. But remember, other immunoglobulins will be normal. There is no doubt about that. Other immunoglobulins will be normal. Clear? So, these are about the selective IgA deficiency. So, what about this common variable immunodeficiency? So, CVID. Common variable immunodeficiency, the problem is completely different. So, in CVID, so I'll write separately here. In common variable immunodeficiency, the main problem is I told you the B cells have to convert into plasma cells. This is the journey, this is the destiny of beta cells. That's why the beta cells are born. So, this is not happening. So, the B cells cannot get converted to plasma cells. The reason, the final thing will be reduced immunoglobulins of all classes. Reduced immunoglobulins of all classes. So that is what we call common variable immunodeficiency. How will you differentiate from X-linked Bruton's A gamma? Because in X-linked Bruton's A gamma globulinemia also, you will have reduced immunoglobulins of immunoglobulin deficiency of all classes will be there. In that the problem is different. The mature B cells itself is not formed. Here the mature B cells will be there, but they cannot convert, they cannot switch into plasma cells. That is the idea. But again, the underlying genetic defect is not clearly known in common variable immunodeficiency. But how will you differentiate in exam? Because if they give two patients who are suffering from recurrent infections and both patients are having reduced immunoglobulin levels of all classes in the blood, what makes you differentiate the single most important point in exam between CVID versus Bruton's A gamma globulinemia? Remember, the onset is later here. Onset is typically in the range of 20 to 35 years, whereas in B-decade deficiency, in Bruton's agammaglobulinemia, you will get in 4 to 6 months of age itself. But here it's very late, it's around 20 to 35 years of age. Typically, the patient will get recurrent sinopulmonary infections. This is not going to differentiate anyways, but still, the onset is what the key is. And the patient also poses a very high risk of lymphomas, autoimmune disorders, and bronchiectasis. And one more clue you might get, the examiner would like to give in common variable immunodeficiencies, there will be poor response to immunization, which means a normal child growing, a child that is growing will be completely normal, poor response to immunizations. So a child will be growing normally, but the response to immunization will be poor. Despite immunization, the child will get infections again and again. So that's again a very important point to understand. Poor response to immunization in the child also goes towards a common variable immunodeficiency. And next thing, the patients will have normal level of B cells and T cells. Again, this is in stark contrast with, your X-linked Bruton's agammaglobulinemia, because in X-linked Bruton's agammaglobulinemia, the B cell count will be low. But here, the B cells and T cell levels will be normal, but the patient will have reduced number of plasma cells. And they'll have reduced immunoglobulin levels in the blood of all classes I told you already. So here sometimes the patient get lymphadenopathy, germinal center reaction are not possible, but not possible in X-linked Bruton's agammaglobulinemia. Here, because mature B cells are there, they try to proliferate, but only the plasma cell conversion is defective. But apart from that, they can form the germinal center reaction also. Lymphadenopathy and all is possible during infections in case of CVID, but it's not possible in X-linked Bruton's agammaglobulinemia. But most important in exam, remember only one point: low immunoglobulins, recurrent infections, early age 4 to 6 months, think about Bruton's, and if it's around 20 to 30 years, think about CVID. That's it. So really easy to understand. So these are the three most important B cell immunodeficiency syndromes. Then we go on to the T cell immunodeficiency syndrome. T cell immunodeficiency syndrome, the most important being the DJOT. So let us discuss one by one separately. So let me put the T cell immunodeficiencies. T cell, the first one is the DJOT syndrome. DJOT syndrome, the mnemonic we are going to call it as something called Catch-22. This is a very famous mnemonic. This is not my mnemonic. It's from when I was studying, I was preparing for MLA and I was preparing for my entrance. From that time, you have this Catch-22 mnemonic. Even before that, my seniors also taught me. So what do you mean by Catch-22? So C stands for cardiac anomalies. C stands for cardiac anomalies, and A stands for anomalous phase. A stands for anomalous phase, and T stands for thymic abnormalities. Typically, they will have thymus hypoplasia or aplasia, absent thymus most of the time. And C stands for cleft palate, and H stands for hypocalcemia. Very important point. Hypocalcemia. And 22 stands for the affected chromosome is chromosome number 22. Typically 22q11.2. So this is the typical chromosome. You can remember 22q or just chromosome number 22. That's an important question in exam. So this is the affected chromosome. This is what we call as Catch-22 syndrome or DJOT syndrome. The spectrum, the reason is, why you get this typical DJOT syndrome is because of this particular defect, this 22q chromosome defect. What it will happen is this third and fourth pharyngeal arches will not form properly. Loss of third and fourth pharyngeal pouches or pharyngeal arches will be there. So third and fourth pharyngeal arches are the ones that give rise to thymus and parathyroid glands. So thymus will not be there. So that is the reason why you don't get the T cells, and parathyroid will not be there. That is the reason why you have low PTH. Because of the low PTH, you will get hypocalcemia. As simple as that. So this is the reason why you get this kind of typical abnormalities in DJOT syndrome. This is also referred to as something called a Catch-22 syndrome. So how will you diagnose in exam? Diagnosing in exam, the typical abnormalities you will see. Apart from that, chest X-ray they might give, which will show absent thymic shadow. So if you remember, if some of you remember what I have taught you in T cell basics in not in T cell basics, in the basics of adaptive immunity. There I have showed on X-ray in the neonat showing a thymic cell, isn't it? That's a very important thing to know, the thymic cell. So that won't be there. That's neonat. It's a very common thing. Prominent thymic shadow that won't be there in the neonat. So absent thymic shadow, very very important. At the same time, they will have low PTH and low calcium, as I told you, and they'll have very very reduced number of T cells because T cells can't form in this. And when you do this thing, there will be this delayed hypersensitivity will not be there. This delayed hypersensitivity is typically cell-mediated immunity, and that won't be there. Because of that, the patient will not get any delayed hypersensitivity reactions. Absolutely not possible. So these are some of the important features of this DGeorge syndrome. With this, we can move on to the next syndrome, that is hyper IgE syndrome. This is the second one of the T cell immunodeficiency, hyper IgE syndrome, otherwise referred to as Job syndrome. The primary problem in Job syndrome we discussed already. It's the STAT3 deficiency. STAT3 deficiency, this is the problem. This is the transcription factor, which I told you. If you take the T cell basics and see, here the antigen presenting cell is there. Antigen presenting cell is going to, typically for extracellular antigens, only this process I will draw. Typically for extracellular antigens, this is the MHC class 2, and they bind it to the naive T cells. And they bind to the naive T cells, and this binding happens through this T cell receptor MHC class 2 interaction. And how this APC teaches the naive T cell that it is an extracellular antigen is by secreting an interleukin called interleukin 23, I told you. At the same time, other things that are responsive, TGF beta and interleukin 6. So once if all these are there, definitely this T cell will get educated and they will become activated T helper 17 clone or T helper 17 cells. For this differentiation, the most important is STAT3. After this only you will get this interleukin 17, interleukin 21, interleukin 22 and all. Interleukin 17 is going to activate the neutrophils and bring the neutrophils to the site of inflammation and create a response. But here the problem is this transcription factor in the T cell is very important. The STAT3 is very important for differentiation into Th17 cells. If STAT3 is not there, you won't get this Th17 clone. You are not going to get this neutrophil activation or this antimicrobial peptide production in the mucosa. So all these things are going to happen. So what are the thing? Why you get this hyper IgE? Because since there are multiple pathways for this particular T cell. So you have T helper 1 pathway, you have T helper 2 pathway. All these things are there. Remember, T helper 1 pathway also, to an extent your STAT3 is important, that is anyway. But one thing that doesn't depend on STAT3 is the T helper 2 pathway. So which means whatever antigen the APC encounters, they cannot move into either your T helper 17, nor they cannot move into your T helper 1 pathway, because T helper 1 also STAT3 is little important but not that much. But any antigen that is exposed, they will be getting response towards T helper 1 only. So the T helper response will be augmented, resulting in the production of excessive IgE. Because I told you T helper 2 is an allergic pathway. So they are going to produce excess IgE, and that is the reason why you get this hyper IgE, or otherwise referred to as Job syndrome. So what are the clinical features of this hyper IgE syndrome? We typically give a mnemonic called FATED. FATED is one old mnemonic for this hyper IgE syndrome, where the patient will have typically coarse facial features, and they will get repeated abscesses. Typically they will get staphylococcal infection. That's what is very common, because neutrophils are very important for that. And T stands for teeth problems. Typically they will not get the secondary teeth, they will have retention of the primary teeth. Retention of primary teeth will be there. And E stands for hyper IgE, and the patient will have significant eosinophilia will be there, and the patient will have a lot of dermatological manifestation in the form of severe eczema, because I told you this T helper 2 pathway is activated. That is a allergic pathway. Lot of IgE, lot of eosinophilic reaction, and lot of eczema, urticaria, severe bronchial asthma in many patients, polyps, because polyps are also due to allergy only. Nasal polyps, asthma, atopy, urticaria, then allergic rhinitis, allergic bronchitis, allergic conjunctivitis, lot of allergic reactions these patients will get. That's why I told you dermatologic manifestation, severe eczema is very, very important. So these are the typical features of hyper IgE syndrome, or otherwise referred to as Job syndrome. Diagnosis wise, the patient will have very much elevated serum IgE and serum eosinophils, and all these things, if happens congenitally, you can suspect this Job syndrome and you can take a genetic testing accordingly. Eosinophilia will be there. All these things are typical examples of Job syndrome. So this is how a Job syndrome works. This is called hyper IgE syndrome or Job syndrome. And the third one, you have something called IL-12 receptor deficiency, and this is an autosomal recessive inheritance. IL-2 receptor. Remember, Job syndrome is autosomal dominant. Job syndrome is typically autosomal dominant inheritance, whereas your IL-2 receptor deficiency is typically autosomal recessive in inheritance. And autosomal recessive in the sense like, what is the defect, primary defect in IL-12 receptor? I told you similarly, you have a antigen presenting cell for intracellular antigens. Intracellular antigens like tuberculosis, one of the classic example of an intracellular antigen in an organism. I told you this is a MHC class 2, they will express these antigens, and this will be recognized by the naive T cell, and this naive T cell will identify through T cell receptor. And how this APC is going to educate this naive T cell that it's an intracellular antigen is through secretion of interleukin called interleukin 12, and through this only this naive T cell is going to differentiate into something called a T helper 1 clone, and the characteristic cytokine of this T helper clone is interferon gamma. This interferon gamma is one going to activate the macrophages. I told you once they activate the macrophages, they in themselves secrete interleukin 1, interleukin 6 and TNF alpha and all these things, and they are going to activate more and more macrophages, and neutrophilic activation all will happen through this TNF alpha related thing. And either if the infection, if the organism is killed, the response will settle, or if the organism is not able to be killed, they'll form a granulomatous reaction and they'll form a local granuloma. So that's how it works. So here the problem is, since the T cell is having IL-12 receptor deficiency, because of IL-12 receptor defect, what is going to happen is this IL-12 is not going to work. If this IL-12 is not going to work, they cannot produce the Th1 clone, which means they cannot produce interferon gamma. Their low levels of interferon gamma will be there, and they cannot produce macrophage activation. All these things are the basic keys for diagnosis of this disorder. So what is going to happen? Typically the onset will be around 1 to 3 years of age. Many of the times the patient will have a disseminated tuberculosis. Again, because TB, most of the, it's an intracellular infection which cannot be cleared, so disseminated TB will be there. They cannot form granulomas, they cannot contain the infection also, they cannot kill the organism also. So Th1 response is not there. Because of that, you get all this disease, and you might get a disseminated fungal infections also. And how will you diagnose? Majority of the patients will have extremely low levels or undetectable levels of interferon gamma, because that's a signature and cytokine of a T helper 1 clone. So that is the reason why they don't have all these things. Then two other T cell immunodeficiency syndromes like Appeser and IPEX, we have discussed in detail on the endocrinology section in the autoimmune polyendocrine syndromes part, but right now we are not going to discuss it. But also remember, Appeser as well as your IPEX comes under the T cell immunodeficiency syndromes only. So now we have discussed the T cell also. Now only the remaining 4 is there, that is the SID, Viscot, Aldrich, hyper IgM and ataxatilinjectase. Each and everything carries its own importance. So first let us see the SID, that's called severe combined immunodeficiency first. So this is also referred to as something called bubble boy syndrome, after a famous case called David Vetter, who spent his entire life within a bubble. So you can see him. So this is what we called bubble boy disease, and you can see this is a child, his name is David Vetter. He died in 1984, I think born in 1971-72, and he spent his entire life inside this bubble. It's a sterile bubble. Everyone who's going inside has to, even NASA helped to create astronaut-like sterile suits to enter this boy, because such a severe disease this bubble boy syndrome is. like it cannot be exposed to even a simple microbial organism also. They will get serious, infections and they're going to die. So finally he didn't die of infection, like that's a very, fun part, even though death is not fun, but still fun part is he didn't die of infection as expected. He died of, graft failure after graft as host disease, where the patient has gone for a stem cell transplant. Because the complication of stem cell transplant, bone marrow transplant, this patient died not because of infection. Anyway, SID. What is the basic genetics of SID? In the basic genetics of SID, you have a lot of defects are there. Two types of defects. One is X-linked receptor type defects are there. Second is autosomal recessive inheritance mutations are there. X-linked recessive is typically due to IL-2 receptor mutations. That is interleukin 2 receptor mutations. And autosomal recessive is due to ADA deficiency. That's called adenosine deaminase deficiency. These are the two things that are very, very important. One is IL-2 receptor mutations and defect, and second is adenosine deaminase deficiency. This is very important for this ADA is important for proliferation of any lymphoid cells, not only for T cells and B cells, any lymphoid cell. That is the reason this patient is going to have both B and T cell defective function. Clinical feature wise, they are going to be typically asymptomatic at birth. They will have all type of infections. They will not be spared of any particular infection. They will have bacterial infection, they will have fungal infection, they will have viral infection, they will have protozoal infection. All types of infections they will have. They are not spared of any one single infection because the combined B12 and BN as well as T cell deficiency. Patient typically goes for chronic diarrhea and they will go for failure to thrive, and they will have absent lymph nodes and tonsils. Many times lymph node hypoplasia and tonsil hypoplasia will be there because there are no B cells and T cells to populate them. That is the reason. So no lymph nodes, no tonsils, chronic diarrhea, failure to thrive, every single infection they will get. Bacterial, fungal, viral, protozoal, all infections. They are susceptible to every single infection in the world. So typically how can you diagnose is through PCR. So through quantitative PCR, this is really important. This might be your exam question. Through quantitative, not qualitative PCR. Through a quantitative PCR, you will see something called low TREX. So this TREX, something I didn't tell you in the T cell basics, but it's really important to understand. Just to understand this SID, this TREX means something called T cell excision circles. T cell excision circle, this is called TREX. These TREX are generally a sign of your T cell maturity. So this doesn't happen because of the ADA deficiency or IL-2 receptor mutation. So this reduced TREX is a very, very important point to diagnose a SID. Very important. Then they will have absent T cells. Typically it happens in X-linked receptor defects, that IL-2 receptor defects, they won't have T cells at all, or they might be having absent T cells, B cells as well as NK cells. If all these three are absent, then it's usually an autosomal recessive variant, that is ADA deficiency, adenosine deaminase deficiency. They will have this picture. So this picture is also very important for exams. And these patients also may have absent thymic shadow because of poor maturation of the thymus. Because thymus has no function here, because the T cells are anyway not going to mature and they're not going to develop. So absent thymic shadow, and lymph node biopsy will typically show absent germinal centers. Lymph node itself will not be there, and the germinal centers cannot be formed because B cells cannot proliferate, as well as T cells also cannot help the B cells, and the T cells also cannot proliferate. So lymph node biopsy will have absent germinal centers, absent T cells or absent T, B and NK cells, and low TREX, especially this is what I believe is the exam question. This T cell excision circles, this will be low. This is a sign of T cell maturity. That will be low. That's one of the important diagnostic criteria for SASCID. That's called severe combined immunodeficiency. Then you have second one, combined immunodeficiency, that is called Wiskott-Aldrich syndrome. Wiskott-Aldrich. Typically, it is X-linked recessive in inheritance as usual, which means it will be seen usually in males, and you are going to see VASP gene mutations. VASP gene mutations. All these are exam questions. VASP gene mutations, because the VASP gene is one thing that is helpful for antigen presentation. If you want to know the function of the VASP gene, it's VASP protein. Protein it produces is very important for your antigenic presentation. So if VASP gene is defective, you are not going to have antigen presentation, so which means reduced T cell function. If you have reduced T cell function, automatically you will have reduced B cell function also. So reduced T cell function is the key here. So this is the problem in VASP gene mutations. Typically onset will be from birth. This is one of the very rare immunodeficiencies that has onset from birth itself because of the symptoms it's going to produce. It's a characteristic triad what you get in Wiskott-Aldrich syndrome. Patient will have a severe eczema. Typically patient will have bleeding diathesis due to thrombocytopenia as well, reduced platelets, and patients will have recurrent pyogenic infections from encapsulated organisms. Recurrent pyogenic infections, especially from encapsulated organisms. So this is what you are going to get. So these are typically VASP gene defects, and VASP gene is important for antigen presentation. That is the defect here. That is because of that you will have a low T cell function, and this is one of the few diseases which has onset right from birth itself. Classical triad is eczema. Patient will have bleeding diathesis due to thrombocytopenia, and third thing, patient may have recurrent pyogenic infections, typically from encapsulated organisms, sepsis and death. That's what happens in Wiskott-Aldrich syndrome. And diagnosis wise, if you see, the patient will have a low IgG and an IgM, but patient will have an increased IgE and IgA. Patient will have thrombocytopenia with, very importantly, small platelets. That's very important because a lot of conditions like Bernard-Solé and all will produce giant platelets. A lot of conditions causing thrombocytopenia, especially autoimmune destruction, may produce giant platelets in the peripheral smear. But this is one condition which produces small platelets in the peripheral smear. But the typical diagnosis can be established by genetic analysis, where you will show VASP gene defects. So that is where you diagnose a Wiskott-Aldrich syndrome. Very important. This classical triad will be there in most of the times in exam, so it's very easy. So please don't forget this classic triad. It's a very important point for exam. Then you have something called hyper IgM syndrome. Hyper IgM syndrome. Hyper IgM was one of the recent questions in AIIMS that's been asked. Hyper IgM syndrome, where you have, this is an X-linked recessive inheritance as well, which means again you're going to see in males predominantly. You remember I told you one thing, once your centrocytes are formed, centrocytes are survived, which means once centrocytes are formed, I told you this has to interact with T cells, and the T cells has to go for stimulate this centrocytes through this CD40 ligand interaction, and this is very important for isotype switching as well, class switching of the antibody. Class switching means typically in our body it means from IgM antibody to IgG antibody. So that this interaction is again very important. But the problem in this particular hyper IgM syndrome is the CD40 ligand is defective. That is from the T cell side. The CD40 ligand is defective. Not the T cells are defective. CD40 ligand from the T cells are defective, which means they cannot class switch, so the IgM levels will elevate. So this is what happens in a hyper IgM syndrome. So what you are going to get in this patient is, it's also called a CD40 ligand deficiency. What you are going to get in this patient is recurrent sinopulmonary infection. Recurrent sinopulmonary infections. Because of that, the patients will have failure to thrive also. And second thing, recurrent infections with PCP, histoplasma, CMV, cryptosporidium. These are typical infections you will get. But in exam you won't get this because it's very difficult to diagnose. They would have given high IgM values, increased IgM values, plus at the same time they will have low IgG, IgA and IgE values. All these things will be low in the blood, but IgM alone will be increased. But very importantly, for confirmation you have to use flow cytometry. You can use flow cytometry, where typically in flow cytometry, because flow cytometry is again very important, typically in flow cytometry you can see the CD40 ligand deficiency. You might get a flow cytometry image where they will mention the CD40 ligand, which is very low. Typical flow cytometry image. There is a separate section on flow cytometry which I will be discussing later on. But anyway, there will be, in flow cytometry typically you will see the CD40 ligand deficiency. This is what will be the exam question. usually. So they will give a flow cytometry picture and they will ask you what is the diagnosis. You can diagnose it's a hyper IgM syndrome, CD40 ligand deficiency. So this is what is going to happen in hyper IgM syndrome. Then finally the fourth one you have, that is ataxia telangiectasia. This is the final one that you are going to see. Ataxia telangiectasia. Remember, ataxia telangiectasia is due to a defect called the ATM gene defect. That's called ATM gene defect. And it is autosomal recessive in inheritance. ATM gene is the one that is important for repairing double-stranded DNA breaks. Double-stranded DNA breaks. So if you cannot, if you have deficiency of this or defective ATM gene or ATM gene product, your double-stranded DNA breaks will not be repaired, which means there will be increased double-stranded DNA breaks will be there that cannot be repaired, and they will go for cell cycle arrest. And they will also result in a lot of other problems apart from immunodeficiency also, which we will discuss. So this is the problem in the ataxia telangiectasia. So finally, what is the clinical features of this ataxia telangiectasia? Usually we will give by 3 A's. First A is progressive ataxia, that is due to cerebellar atrophy. Very important. This progressive ataxia is due to cerebellar atrophy. And third one is this, second one is this typical spider angiomas. Spider angiomas, that is the second A, spider angiomas. And the third one, patient will have IgA deficiency. IgA deficiency. So because of the IgA deficiency, patient will be prone to increased susceptibility to a lot of infections. Like patients might have sinusitis, patients may have pneumonia, sinopulmonary infections, patient will have otitis media or ear infections, and patients may have a lot of diarrhea also and failure to thrive as well. Apart from that, these patients have very much high sensitivity to radiation. Even small amounts of radiation, even like our routine x-rays also may damage the genes of these patients like anything, because radiation causes double-stranded breaks, and normally simple radiations for us, double-stranded breaks will be immediately repaired by the own cell itself. But these patients cannot repair this double-stranded breaks, and they are highly prone for radiation-induced injury and damage. Number one, increased radiation-related damage. Increased radiation sensitivity or radiation hypersensitivity will be there. And second thing, even small amount of X-ray, normal routine chest X-ray may cause burns in this patient. That's why it's very important to avoid any form of radiation to these patients. And second thing, they have very high risk of malignancy, because if you are not going to repair this double-strand DNA breaks, they have high risk of malignancy, especially lymphomas, leukemias and all are at very, very high risk in this patient. So high risk of malignancy and very high risk for radiation-related damage. And remember, one more important syndrome that has very high risk of malignancy is your Wiskott-Aldrich also. Wiskott-Aldrich also has a high risk of lymphomas and leukemias, hematological malignancies. And how will you diagnose this? Typically in MRI you will see cerebellar atrophy. This is a very classical point in exam. And very important, another point is increase the AFP levels, alpha fetoprotein levels, and this also is many times asked question in exam. At the same time, patients will have low levels of IgA, probably IgG, Ig and all these things, and patients will have lymphopenia. Lymphopenia may be the feature. But very important, these 3 A's you have to remember in exam. The patient will have progressive cerebral ataxia, and onset, if they ask you, typically it happens in early childhood. So not in late adulthood or adolescent period, early childhood around 5 to 6 years of age itself, all these things will start. Ataxia, spider angiomas and IgA deficiency, because of the patient will have recurrent infections throughout their life, and they are also prone for like getting hematological cancers like lymphoma and leukemia, and also they are also highly sensitive to radiation. Even simple radiations also may cause extensive injury to these patients because of inability to repair this double-stranded DNA breaks because of the ATM gene defect. So with this we have concluded our B cell basics and the immunodeficiency segment also. Remember, this immunodeficiency is really important, especially the genetic defects underlying. They are repeatedly asked questions, and the most important immunodeficiency disorders, if you ask me, it is SCID, Bruton's A gamma globulinemia, common variable immunodeficiency, selective IgA deficiency, Wiskott-Aldrich and ataxia-telangiectasia. These are the 6 immunodeficiency syndromes that you have to know. Recently, hyper IgM syndromes are also has been asked. But anyway, this immunodeficiency itself is a very high yielding area which you have to definitely know. So with this, we can conclude this B cell basics part, which is really extensive, but really important topic as well. So we'll move on to the next topic, that is we are going to see the lymphomas proper. We are entering the proper clinical medicine in the next video. See you.